talk delivered in Chandigarh only, that is of fetal aorta, and how do you make an assessment by echocardiography, fetal echo. Yes, good idea to subscribe the channel, because the moment I post a new one, you would be notified, and I would continue to post many educational videos for you guys. And I'm just going to share you few tips and tricks for making an assessment of an aorta of fetus. And that's how I'm going to share. I'm going to tell you about the normal values, the introduction, and then I would tell you about large aorta. If you get a large aorta in fetal echo, what is the differential diagnosis? If you get a smaller aorta, what is the differential, and what is the artery which is coming out of the left ventricle is not aorta. Okay, so then another when you don't see aorta at all, right? And then at the end I would tell you how to prognosticate each of the category of patients, and consult the patient's family accordingly. How do we assess aorta? Aorta is visualized by a cranial angulation of the ascending the scanning sector from a 4-chamber view to an LVOT view, and going little more cranially till you achieve a 3-vessel trachea view. In that process, what you achieve is, first you achieve a apical 5-chamber view. Okay, or you can do that in a parasternal long axis view, that another view of viewing aorta. You can view the aorta by a short axis view, that is the origin of aorta, if you see, by 3 various orthogonal planes, and they are all important because they are going to tell you various angles, and there are structures which are best seen in either apical 5-chamber, and there are some structures which are seen best in parasternal long axis view, that is the lateral 4-chamber view, then going into LVOT. From the RVOT we angulate up, and the aorta is kind of missing there because you have a pulmonary artery. Aorta circles around the pulmonary artery, and then it comes back and joins the pulmonary artery through ductus arteriosus, and that is what we call as a 3-vessel trachea view. This is an RVOT. Then you see the aorta going behind this, and this is where the aorta is coming on the right side of the pulmonary artery, and when you go on a 3-vessel view, this is the aorta, that's the pulmonary artery which is lying superiorly. It goes under the pulmonary artery and then goes to the right side, then turns to the left to join the ductus arteriosus here, forming a 3-vessel trachea view. Now lateral view, for example, the lateral view of I'll show you. This is apical 5-chamber view. It's okay to see an overriding of an aorta, but for subaortic VSD, the lateral view, lateral 4-chamber, giving rise to the parasternal long axis view, is the best to see because here the VSD flows are seen which are actually perpendicular to our scanning jet. You can do a short axis view like here. That's the short axis view of aorta, and this is typical circle and saucer appearance of a normally related great arteries. Here you, in case there is a VSD, then you can see a VSD. Let me tell you how the VSD can be seen in this position. Okay, let me scroll it up and down in here, right? So that is a right atrium, if you recognize the structure, because this is not a commonly used views in fetal echo, but this is the right atrium, this is interatrial septum, tricuspid valve, this is the right ventricle, and this is the right ventricular outflow tract, this is the pulmonary valve, pulmonary artery. The artery which is going behind the aorta is the right pulmonary artery, and this one is the left pulmonary artery, which is, and the ductus arteriosus. Then this portion of the aorta where the VSD is seen, if it is seen close to the tricuspid valve, it is called a perimembranous VSD. If it is seen right here in the middle, then this is called an outflow VSD. If it is seen just below the pulmonary valve, it's called a subpulmonary or doubly committed VSD. So that's where on a cross section you see, again I'm repeating, perimembranous VSD close to the tricuspid valve, right in the middle of this right ventricle. Then this is an outflow tract where this outflow is starting just close to the pulmonary valve. So you get a subpulmonary, perimembranous, outflow VSD and subpulmonary VSD. So this is where another thing what you see in this cross section is whether the aortic valve is bicuspid or trileaflet. So these are the advantages of a short axis view looking at the aorta and the aortic valve. Let us see the normal anatomy of the aorta. We divide, first we have an aortic root. There is slight bulge here which are called sinuses of Valsalva, and from here sinuses you get origin of left and the right coronary arteries. Then you have this portion right up till the origin of the first branch of the aorta, the brachiocephalic, and this portion from this sinus is called ascending aorta. Then these innominate or brachiocephalic arteries arise, the left common artery, the right common carotid artery, and subclavian artery. And then this is where this portion till the isthmus is called the arch of aorta. And then the portion from the left subclavian artery origin is called a descending thoracic aorta. You can see the same things here. That's the aorta. You don't see the aortic valve here very clearly. Probably this is the aortic valve. Then this is an ascending aorta. This is the first branch dividing into right subclavian and right common carotid artery. From here, from the origin of the artery, the common artery, to the descending to the left subclavian, this portion is arch of aorta. Prior to this and the sinuses, this portion is the ascending aorta. Then the portion subclavian artery, just distal to the subclavian artery, is the narrowest portion of aorta called isthmus. And then you have a descending aorta or a descending thoracic aorta. To take a measurement of size, that's very, very important. You must always use the z-scores, because if you have to follow up the patients, you have to compare it with the z-score of the aorta. The best resource of z-score could be your equipment itself. Many equipments these days offer you z-scores when you're making a calculation there, but you can use this resource of parameters blog, and this blog can show you all. What you need to feed is that you give first either the expected weeks or other parameters, and then you feed in the various measurements, and it will give you a z-score of each measurement. The first thing which I am going to show you is the dilated aorta, and the very first case is a tetralogy of Fellows. And what you see here is a 50% override. Remember, the override percentage is best calculated in a 5-chamber view, because it's not as good and accurate once you are doing a lateral or a long axis view from the parasternal area. So this is a 50% override, and you see the outflows from right and left ventricle are actually filling the ascending aorta. Then you see the pulmonary artery is smaller than the aorta, and it's joining right in the middle of the aorta. Normally what you would have expected, that's the aorta and the pulmonary artery, and from here the ductus would have come and joined here at the tip, making a V, but this is making a T like this. So this is one part of the T, and that's the horizontal part of the T. You notice here the red color flow, which indicating the flow reversal in the pulmonary artery, indicating a severer pulmonary stenosis. So now this is another patient of tetralogy of Fellows with a very large aorta. Severity of tetralogy of Fellows depends upon the degree of pulmonary artery stenosis. Smaller the pulmonary artery, larger would be the aorta. So that's how you make up an assessment of tetralogy of Fellows severity. This patient has a marked left axis deviation, axis about 80 to 90 degree. So now this is the same patient where you saw the aorta, and then you have a descending aorta where you see, and that's the descending aorta where you see the MAPCAs or main pulmonary artery collaterals coming out of the aorta. So this is a patient of pulmonary atresia where pulmonary arteries are arising from the descending aorta. So that's another interesting case. What you see here is a kind of a common AV valve. Both atria are actually draining through the common AV valve into the right ventricle. Left ventricle is small, there is a small VSD, and the left ventricle is kind of rudimentary. This is a situation like double inlet right ventricle. The both atria are draining into the right ventricle. Now this is the main artery coming from the RV, which is an aorta, which is large, and there is a pulmonary atresia, and from the pulmonary artery you see the central collaterals are coming from, or pulmonary artery is being formed by the central collaterals coming from the descending aorta at the level of 4-chamber view. You can see this one pulmonary vein. This is the descending aorta cross section, and you see the right pulmonary artery coming out there. You see the left pulmonary artery coming out of there and supplying the lungs. Dilated aorta could be because of just a solitary dilatation, little beyond the proximal part of an aorta before the ascending aorta starts, and that's the pathological specimen of the same patient. You had a dilated aorta, and the most common reason for dilated aorta is a bicuspid aortic valve. And same, there is a patient of increased velocity across the aortic valve and dilatation of the aorta, and the commonest reason, as I told you, of dilatation of aorta is a bicuspid aortic valve and causing a mild to moderate aortic regurgitation. This is a patient which is showing a significant elasing at the level of an aortic valve. This indicative of aortic stenosis, and you have an ascending aorta dilatation. Again, this patient, the same patient, showing ascending aorta dilatation predominantly before the first origin or the first branch, and this aorta dilatation is because of aortopathy related with the bicuspid aortic valve. Same patient from another angle and a view, you see elasing of the blood and you see dilatation of the ascending aorta, and the velocities are crossing 250 centimeter per second, indicating moderate aortic stenosis. Same patient, another patient showing increased velocities of aortic valve, and you see this is a typical bileaflet aortic valve. This is the bicuspid aortic valve, and if you see it further, you see the valve is thickened and doming, and you see elasing of blood, indicating that this is a patient with aortic stenosis. The same patient, because you must remember, patient with the bicuspid aortic valve have a common association with the coarctation of aorta, and this patient had coarctation of aorta. You can see these ridges here, and you can see the diastolic hold of the blood, which are kind of characteristic of the coarctation of aorta. So another case of dilatation of and the entire aorta, and the reason there is aortic regurgitation, and that's the moderate to severe aortic regurgitation. This is the valvular aortic regurgitation because of an abnormal aortic valve. So that's a different patient where you see there is a dilatation of the right ventricle and the right atrium, and then you see this is an aorta which is overriding, and there is a dilatation of the aortic root, and that is happening because of aortic regurgitation as well as mild aortic stenosis. We did present one patient with absent cusp of aortic valve. There is a forward flow and there is a regurgitation, and this is the reason of a dilatation of aorta because of the severe aortic regurgitation, forward flow and the retrograde flow on the aorta. And on an autopsy we could see the non-coronary cusp was actually absent and other cusps were thickened and myxomatous. Compare this with the normal pulmonary valve of the same autopsy specimen. Then if the aorta is small, when the aorta is small, these are your differentials. It could be a coarctation of aorta, it could be a severe aortic stenosis, it could be aortic hypoplasia, which could be a part of hypoplastic left heart syndrome, or there could be interruption of an aortic arch. When you don't see anything else and you have a small aorta and then you have a VSD, just must keep a very strong suspicion of interruption of an aortic arch. This is the large VSD, LV and RV inflow signals, and you see this VSD which is actually filling the left ventricle. And when it comes to the aorta, now this is the pulmonary artery which is large, you see the aorta is small. Same patient, another patient where you see the aorta is small and you see it bifurcates here, and there is a strong suspicion of interruption of an aortic arch. Another patient with a small aorta, and that's a patient with the hypoplastic left heart. You see the LV is globular hypocontractile because of the severe aortic stenosis causing aortic hypoplasia, and that's the increased flow across the aortic valve. Same patient where you see the LV is globular, there is severe mitral regurgitation. You see this patient on a 3-vessel view, there is a retrograde flow of in the aorta indicating severe proximal obstruction to the aorta. So then what if what you were thinking was aorta is not aorta? Now this is LV and you think this vessel coming out of this is aorta, but it suddenly dips down and bifurcates. This is a typical sign of transposition of great arteries. This is not aorta, that's the pulmonary artery. So you see this is pulmonary artery which is branching into two, coming out of the left ventricle, and then you have other signs of a parallel vessels, and aorta is coming from the right ventricle and PA is coming from the left ventricle which is branching. So be sure that what you're thinking is aorta, is it really aorta? It could be a pulmonary artery. Then again, when it may not be an aorta, when you see the aorta arising from the override from both right and the left ventricle, and that actually it was not aorta, that was the truncus which was dividing into two, pulmonary artery and aorta. So that you get a dilated vessel which looks like aorta, but it's not aorta, it is the truncus or a common arterial trunk which divides into two branches, that is the main pulmonary artery LPA and RPA originating from the truncus arteriosus. Then you don't see any aorta. You have a large VSD which is an egress for the left ventricle, but when you do on a 3-vessel view, you see a small artery which is filling retrogradely, which is aorta. So there is no proximal origin of aorta. The aorta is filling retrogradely because aorta is supposed to supply the coronary arteries, and that it does through the retrograde flow. So now this is aorta. You can see these are the coronary arteries. I am going to show you what are the coronary arteries look like. Now I'm pausing it here, scrolling, and that's the coronary artery, right? So this is the right coronary artery going this way. This is the aorta filling retrogradely, trying to fill the arteries. This is the right coronary artery, the left coronary artery. So it's important for aorta to fill retrogradely to supply the coronary arteries. Then the next uncommon rare thing is aortopulmonary window. That's in proximal aortopulmonary window. It's very difficult to pick up. Normally you get some dropout here, and you have to be very sure this is AP window rather than just a simple dropout. And this is the distal type. Now you have a pulmonary artery, that's an aorta, and that is an AP window. Another patient of an AP window, which is a distal AP window where the aorta is small. You see this is the portion where there is an AP window. I'll just try to scroll and show you here, and that is where the communication between the pulmonary artery and aorta, and this is an AP window. I think here I would take this talk a little later on the aorta, the V sign, the double aortic arch, and I would skip something here, and I would stop short here to give you an idea that okay, these things of aortic arch abnormalities I would probably like to connect in a subsequent talk. So keep learning. Wait for my other talk on the arch abnormalities, which I'll post shortly. And then how would you come to know? Yes, subscribe the channel. You would be notified when I'm going to present you the second part of abnormalities of